Good afternoon and welcome to Wednesday Wellness, a free live educational series by Trinity Health. We're thrilled to have you join us as we discuss stroke prevention and lifestyle changes that can make a difference. Before we get started, here are a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A chat feature at the bottom of your screen. Questions will be addressed at the end of the presentation. Lastly, today's webinar is being recorded and a link to the video will be sent to your email. Without further ado, I am pleased to introduce Dr. Kasim Qureshi, a board-certified neurologist with Trinity Health Medical Group.
Hi, thank you for the introduction. I'll be talking today about lifestyle changes that can make a difference in stroke prevention. An outline of what we'll talk about today, we'll go over a brief overview of stroke. We'll talk about how we can classify the prevention of stroke and how we can classify risk factors related to stroke. And then we'll get into some lifestyle changes covering diet and nutrition, physical activity, smoking and alcohol, stress and sleep, as well as regular health screenings. So what exactly is a stroke? A stroke is a medical emergency caused by either interrupted blood flow or bleeding to the brain. As you can see in the top right picture here, there's a big dark area of the brain, and that is a part of the brain that has died due to a blood clot interrupting blood flow there. That type of stroke is called an ischemic stroke. In the bottom picture, you see that bright white area within the brain, and that is an area of fresh bleeding in the brain, also known as a hemorrhagic stroke. Now, many of the things we talk about today will apply to both types of strokes, but we should note that ischemic strokes are more common and is generally what we talk about when we're talking about stroke prevention. Stroke is a big deal. It is the fifth leading cause of death in the United States, and it is a leading cause of long-term disability. And about 80% of strokes are felt to be preventable, which is why we want to focus on some of these risk factors. When we talk about preventing stroke, we can lump it into two main categories. On one hand, we have what's referred to as primary prevention of stroke. These are things that people can do to prevent them from having a stroke in the first place. Many times we also talk about secondary prevention, and this refers to preventing a stroke in someone who has already had one. So preventing a second or third stroke from happening. We can also classify our risk factors related to stroke in several different ways. One of the ways which we can classify them is referring to them as non-modifiable or modifiable. As the name would imply, non-modifiable risk factors are ones that we cannot change. For instance, our age, our family history or genetics, or our ethnic background. Modifiable risk factors refer to ones that we can change. And these can be medical conditions such as high blood pressure, diabetes, obesity, high cholesterol, or atrial fibrillation. And they can also be lifestyle factors, many of which we'll discuss today. When it comes to diet and nutrition, there's a lot of research and data out there that studies what has been best for preventing strokes and promoting cerebrovascular health. There's two main diets that have the most evidence for them. They're called the DASH diets and the Mediterranean diets. The DASH diet is particularly helpful in people who have high blood pressure. In general, with this diet, it's encouraged that we reduce our sodium intake and increase our potassium intake. On the right side here, we have a graphic depicting the DASH diet. And as you can see here in the first column, there are several things that are recommended, such as vegetables, fruits, whole grains, fat-free or low-fat dairy, fish, poultry, beans, nuts and seeds, and vegetable oils. There's certain things that are also recommended to be limited. So these are fatty meats, full-fat dairy, sugar-sweetened beverages, sweets, as well as sodium intake, like I mentioned. In addition, there's some evidence for vitamins that may be beneficial in preventing stroke. And the main evidence that we have is for folate as well as B complex vitamins. The Mediterranean diet is one that's been studied extensively for preventing stroke and has the most evidence to support it. Oftentimes, we recommend a Mediterranean diet to our patients, but we fail to go into it a little bit deeper. So I wanted to show this graphic from the Cleveland Clinic, which goes into a little bit more detail about what exactly a Mediterranean diet is. There's certain things that are recommended to be that we should have at every meal. So these include fruits, veggies, whole grains, and extra virgin olive oil. There's another category of foods that are recommended to have 3 times a week. These include fish and seafood, nuts, and legumes. And then we have some food groups that are recommended to be limited. So limiting your serving to once per day is poultry, low-fat dairy, and eggs. And then limiting your serving to once per week would include red meat and sweets. We won't go through this whole list, but I would like to point out that there's a lot of information online about specific things that go into a Mediterranean diet. This is another great resource from the Cleveland Clinic, and you can also find a similar resource from the NIH, going into a lot more detail about what specific vegetables, fruits, grains, and nuts, seeds, and legumes are recommended in a Mediterranean diet or constitute a Mediterranean diet. We often talk about what diet is recommended and has the most benefit, but we should also talk about how do we change dietary behavior. As many of us know, this can be easier said than done. But here are some tips on how to implement some changes in either your diet or your patient's diets. First of all, setting a specific goal that is reasonable and attainable to achieve is really setting yourself up for success. We know that monitoring and recording your dietary intake, usually through a diary, is very beneficial in changing your dietary behavior as well as other types of behavior. Recognizing and managing situations that may lead to dietary lapses is very important. It's also helpful to modify your environment to minimize any exposure you may have to unhealthy foods. And lastly, we can always benefit from getting support from our social sources, our friends and family around us who may be around us while we're trying to make these dietary changes. Moving on to exercise. The benefit of exercise in stroke prevention cannot be understated, not only for stroke prevention, but for heart health and also general brain health overall. The general recommendation is quite intensive. It is recommended that we aim for about 150 minutes of moderate intensity exercise per week and about 75 minutes of vigorous intensity physical activity. We also know that besides exercise, what's harmful is excessive time in sedentary behavior. So that's time sitting in a chair, laying on a couch, or laying in bed while you're awake. And that's what we would classify sedentary behavior as. We can all take little tips to increase our level of exercise. So simple things that you can do in your day-to-day or recommend to your patients, taking stairs instead of elevators, taking the opportunity to walk when you have multiple options, parking further away. When you have a lunch break, taking some time to go for a walk. And again, similar to trying to implement dietary changes, tracking your movement can always help. So using a fitness tracker or pedometer or a smartwatch can help us improve our level of activity and exercise. One of the major changes that we can make, especially with many of our patients, is smoking. Smoking greatly increases your stroke risk. It almost doubles the stroke risk. And we know from extensive research that the benefits of quitting smoking start to rise within only several weeks. Smoking can be quite difficult quite a difficult habit to quit, as many of us know from treating our patients who have tobacco dependence. And what we know is that the most effective way to help stop smoking is a combination of behavioral interventions as well as medications. And there are many medication options out there that can help. And when it comes to medications, using a combination of some nicotine replacement as well as some medication is really what's most effective and has been shown to be most effective over time. And there's also other resources out there to support patients who are trying to quit smoking, including phone helplines, apps, and other support groups. I'd like to move on to talking about alcohol and drug use. In the past, there was some information out there suggesting that light to moderate intake of alcohol may be beneficial in preventing cerebrovascular disease as well as cardiovascular disease, so brain and health disease. With time and with more research, we've found that alcohol consumption is related to many other negative health consequences. Specifically, it's associated with development of many different types of cancer. And as many of us may have seen, the Surgeon General's warning last year against any alcohol intake at all. So really, even light to moderate alcohol intake is no longer thought to be of as okay, because even though there may potentially be slightly reduced stroke risk, there are many other negative health ramifications. We also know that heavy alcohol increases the risk of stroke, and this has been consistently shown in many studies. The more alcohol you drink, the more at risk you are of stroke. We have also seen an increase in the use of marijuana with the legalization over the last several years. And we know again that marijuana increases the risk of stroke. Most of our evidence supports that. There are specific drugs that are very associated with the increased risk of stroke, those being cocaine and amphetamines. Cocaine in particular, especially crack cocaine, greatly increases stroke risk through various mechanisms. Both of those medications increase blood pressure, they cause inflammation in the blood vessel walls, and can cause strokes via several different mechanisms, both ischemic and hemorrhagic or bleeding strokes. Stress plays an important role in our overall health, and it does too with stroke as well. Chronic stress has been associated with an increased risk of stroke, found through large epidemiological studies. There's many things that we can recommend for trying to manage stress effectively. Things like meditation, deep breathing, yoga, journaling regarding the stress can be effective. Building social connections, and also seeking professional help when it may be needed. Sleep is also crucial to our overall health, and understandably is also crucial to preventing strokes. Certain sleep disorders, such as sleep apnea, have an association with stroke, have an association with elevated blood pressure, and also cardiovascular health. And the general recommendation is that if sleep apnea is untreated or undiagnosed, that patients begin treatment for stroke prevention. Besides sleep apnea, overall sleep quality and sleep duration is also important. We find that less than 7 hours and also greater than 9 hours of sleep per night are associated with an increased stroke risk. We know that poor sleep can result in increased inflammation in the brain and is unhealthy for the brain overall. Lastly, the focus of our talk today was primarily on lifestyle factors. So we touched on diet, exercise, smoking, alcohol, and drugs. But other modifiable risk factors do include our health or our patient's health. So it's important to keep an eye on and address these underlying risk factors for stroke. And the most important ones are high blood pressure. In general, we recommend a goal of less than 130/80 for stroke prevention. There are certain situations where that blood pressure goal may be a little bit difficult, but for the most part, it's less than 130/80. Diabetes and high cholesterol are very important risk factors for stroke. So making sure diabetes and cholesterol are under good control is very important. And it's a good idea to monitor your numbers, know where your blood pressure is running, know where your sugars are running, and know where your cholesterol is at so you can make the correct changes or work with your primary care doctor to make those changes. We talk a lot about what changes that should be made, but we should take some time to also talk about how those changes should be made. And similar to how I mentioned with the diet, it's important to set an attainable, realistic goal. It's hard to make drastic changes at once, and it's more effective to focus on 1 to 2 lifestyle changes at a time. There's other tricks that we can use. So something referred to as SMART goals. So setting a specific goal that is measurable, achievable, it's relevant, and is time bound. So setting yourself a deadline by which you want to achieve that goal. Habit stacking is a great trick to implement a lifestyle change, and that refers to combining a new habit that you are trying to, well, something new that you're trying to turn into a habit with something you already have. For instance, when you come home, you exercise. If you're trying to start exercise, you come home and you exercise, and you associate coming home with exercising, and that's what habit stacking is. Tracking your progress again with apps or journals forces you to make a conscious effort in documenting your progress and can help you attain these lifestyle changes. There's a lot of support and resources out there for making changes. So if you're a patient, working with your doctor closely, visiting them regularly for screenings, keeping an eye on those things like blood pressure, high cholesterol, your hemoglobin A1C to monitor for any diabetes if you're diabetic. Through Trinity, we have a lot of programs. We have stroke support groups. If you've suffered from a stroke, we can get you established with those, and you can meet with folks from our team as well as other people who have suffered a stroke to hear what they have to say and get any advice from them about how to make some certain lifestyle changes. It's always helpful to have somebody who is keeping an eye on your change. So whether that's a partner, somebody else who can keep you accountable for making those changes always goes a long way. Stroke is very common, like I mentioned. It's the 5th leading cause of death in the United States, unfortunately, and it is one of the leading causes of disability in this country. And as such, there are a lot of resources online that can help you and give you more information on what changes you should be making, what changes you can be making, and how to make those changes. 2 of the biggest resources that we have are the CDC, and the CDC website has a ton of information on stroke prevention, as well as the American Heart Association, the American Heart and Stroke Association, which is the main association that oversees stroke in the United States. I want to leave you with this graphic here, which is Life's Essential 8. This is a new initiative from the American Heart Association that basically covers what I talked about during this talk. So I encourage those of you listening to look this up online. These are what the American Heart Association now recommends we focus on to promote various aspects of our health, specifically our cardiovascular health, so our heart health, as well as our brain health. And that refers to not only stroke prevention, but also dementia prevention. So the Life's Essential 8 refers again to sleep, diet, exercise, monitoring your blood pressure, monitoring your weight, monitoring your high cholesterol, smoking as well. So I'd like to finally end off with leaving those of you listening with a couple of questions. So if you're somebody who's had a stroke before, or if you're somebody who hasn't had a stroke before but has some risk factors, or if you're somebody who's taking care of patients with stroke, what's one change you're ready to make, or one change that you're talking to your patients about making, and what's the biggest barrier? Identifying that first barrier to making that change can be a good first step before you start implementing that change. And what if you're doing well on your own, what are some other steps that you can take to support others around you who may be at risk of having stroke or preventing stroke? Thank you very much. We can take some questions now if anybody has questions.
As Dr. Kresge mentioned, we will now transition into our Q&A session. If you haven't already, you may submit your questions using the Q&A chat feature at the bottom of your screen. And then we will kick it off. I believe you may have answered this, but just wondering, can sleep apnea affect a stroke?
Thank you for that question, Frank. Sleep apnea is associated with stroke. So there's many studies that have showed that untreated sleep apnea is associated with stroke. Untreated sleep apnea is also associated with increased blood pressure. And so in general, one of the things that we screen for, or I screen for in my patients that have a stroke, is to ask them if they have symptoms of sleep apnea, or if I know they have sleep apnea, I oftentimes get them on treatment if they're not being treated already. So there's definite associations with sleep apnea and stroke, and it's generally in our stroke patients something we want them to be treated for if they do have it.
Thank you. We will move on to our next question. If someone is having a stroke, is there anything that can be done before medical help arrives?
This is a fantastic question. It's unfortunate, but many of the strokes, or the majority of strokes that we treat in the United States today, patients arrive too late to the hospital. There's a crucial window in which we can treat stroke. Nowadays, there's things that we can do to stop a stroke in its tracks in the first couple of hours. Once you get outside of those first couple of hours, we're very limited in what we do because the stroke has essentially finalized. So I'm very thankful to the person who brought this question up, because I want to emphasize, first of all, when you have symptoms of a stroke, it's crucial to call 911 and get to the emergency room right away. Really, if we can get to you in that first hour of you having symptoms, there's a lot we can do to help save the brain. So warning signs of a stroke, I'll go over them briefly and then I'll answer the question, are sudden weakness that affects one side of the body or the other, sudden numbness that affects one side of the body or the other, sudden inability to speak, or if somebody is speaking, the words are coming out and it sounds like complete gibberish, like it makes no sense whatsoever. Sudden vision loss is a sign of a stroke. And lastly, suddenly feeling as if you're very drunk. For example, your words are coming out very slurred, you're stumbling and you can't keep your balance, things may be spinning around you. That can also be a sign of a stroke. Now, here's a challenge with what to do before medical help arrives. The challenge is that you have two main types of strokes. One is where there's bleeding in the brain, and the other is where actually the blood supply is cut off. So it is actually the complete opposite thing happening in those two processes. On one side, you have bleeding in the brain. On the other side, you have no blood coming to the brain. And the challenge is that if you have somebody in front of you, if you put a patient in front of me right now, I can tell you that they're having a stroke, but I don't know what type of stroke they're having because they look identical on the exterior surface. That's why we need to get patients into the emergency room right away. That's why we need to get a CAT scan first to make sure they're not bleeding in the brain. So unfortunately, there's not a whole lot that you can do for somebody before medical help arrives. We don't recommend giving aspirin. We don't recommend giving them any medication of any sort. So we're very limited in what we can do for a patient before medical help arrives, unfortunately.
Thank you. Our next question is asking, if you have vertigo, can that cause a stroke?
This is a common question that we get. So vertigo refers to, the neurological definition refers to either a sensation of your surroundings spinning around you or moving around you, or it refers to a sensation that you are moving in your surroundings. Some people have that. Some people can you experience a room spinning around them. For some people, it feels like what you would feel when you're standing on a boat and the boat is in kind of a lot of waves. And so symptoms like that are what vertigo is. And that is what vertigo is. Vertigo is a symptom. And vertigo can be caused by many underlying medical conditions. It can be caused by things going on with your ear, with the balance center in your ear. So that can cause vertigo for people. And then vertigo can also come from the brain or the balance center of your brain. So I want to emphasize that vertigo is a symptom. It can be caused by many underlying things, and a stroke can cause vertigo. So if you are experiencing sudden severe vertigo, especially if you've never experienced it before, you don't have a prior medical reason for experiencing vertigo, it is potentially a sign of stroke. Vertigo in and of itself, since it's a symptom, can't cause a stroke. So it's the other way around. A stroke can cause vertigo.
All right, thank you. If you've had one stroke before, is it possible you will have another stroke?
Yes, it is definitely possible, and in fact, you will be at increased, um, uh, you'll be at increased lifetime risk for stroke if you've had one already. Now, there's a lot of variability that comes there. Some people who've had a stroke are at higher risk of having another one. For instance, somebody who has a stroke because their cholesterol is very high, their diabetes is uncontrolled, their high blood pressure is uncontrolled, and they have a stroke, they are at a very, very high risk, essentially almost a guaranteed risk of having another stroke unless those symptoms or unless those underlying medical conditions are addressed. So, and then there's other patients who may have a stroke from a very specific, definite reason. For example, one of the most common causes of stroke in the United States is an abnormal heart rhythm called atrial fibrillation. And that's a heart rhythm that causes little clots to form in the heart and go up to the brain and cause a stroke. And so, if you have a stroke from atrial fibrillation and then you're put on the right medication for it, which is a blood thinner, that greatly, greatly reduces your risk of stroke. So it doesn't get it down to 0%, but it gets it pretty low into the single digits. So in general, essentially everybody who has had a stroke is at increased risk of having another one. But within those patients, there is a lot of variability on how high that risk is, depending on what caused the stroke.
All right, thank you very much. Our next question is asking if you can confirm if an oral nicotine pouch increases risk stroke.
So this is a debatable topic. So in general, in general, there is some debate that or there's some concern about using a nicotine patch in the hospital immediately after a stroke. But the evidence surrounding it is pretty poor. So I routinely use nicotine replacement therapy in my patients, especially in the outpatient setting once we're outside of the hospital setting for a stroke. And it's pretty debatable. It's a bit of a gray area where we don't know for sure whether or not it's safe. Depending on the type of stroke patients have in the hospital, I do sometimes use nicotine replacement therapy even in the hospital safely.
All right, thank you. Next question, are you able to speak about heat-related illnesses and strokes, for example, heat stroke versus regular stroke?
Yeah, so a heat stroke is a little bit of a it's not exactly related to the strokes, like the regular strokes that we're talking about. So the regular strokes that we were talking about today, for example, are a are when you either lose blood supply to the brain, and so that causes a little area of damage, um, or you can have bleeding stroke where there's bleeding in the brain. A heat stroke is a little bit of a different phenomenon, and really what it is when somebody is in a very high temperature environment, with a high humidity environment. It can cause some dysfunction in their brain overall, and it results in them just kind of their nervous system going haywire for a period of time. So it's a lot different from the types of strokes we were talking about today. It is honestly a little bit of a misnomer because it's not really related to the types of regular strokes we were talking about today.
All right, thank you. Our next question confirms, I think reiterates that you mentioned salt intake is essential. How much is too much?
I agree, salt intake is essential. So we cannot survive without salt. The answer to that question really depends on your underlying medical conditions. So it's hard for me to give a definite answer without knowing someone's medical conditions. For example, someone who has heart failure, or who has bad heart failure has to severely limit their salt intake. And for people who may just be hypertensive, but their medications are controlled, or sorry, their blood pressure is controlled on medications, they may not necessarily need to be as aggressive with limiting salt intake. For someone whose blood pressure is uncontrolled on medications, it's probably a good idea limiting salt intake some more. And if it's somebody who has mildly elevated blood pressure and is wanting to not trying to avoid starting medications, that's somebody who could try some aggressive salt intake limitations. So it's very variable depending on your underlying medical conditions. And I would encourage you to ask your primary care doctor who's familiar with all your medical conditions, and see if they have a specific recommendation for you.
All right, thank you. This next question has a little bit of a two-part to it. The first question is asking if you know of any substitutions for amphetamines, and then the second question is asking if sleep aids can contribute to a stroke.
I'm going to assume that this question is referring to prescription amphetamines for ADHD. Obviously, for recreational drug use, like methamphetamines and things like that, used recreationally or illicitly, the best is nothing. For prescription amphetamines that are used for ADHD, it's a case by case basis. So if you have had a stroke, it's generally recommended that you stop taking amphetamines. There are non-stimulant medications out there that can treat ADHD, and there's a couple of antidepressants that can be used. And then, of course, there's always the non-medicinal approach. So trying cognitive behavioral therapy through a psychologist can be really effective for treating ADHD. So yes, there are non-stimulant medications out there that can be used instead of amphetamines for ADHD if you have had a stroke. As far as I'm aware, sleep aids do not contribute to a stroke. However, there is increasing evidence that they may contribute to dementia. And certain sleep aids out there, especially some of the antihistamine ones, we're finding more recently that can be associated with the increased risk of dementia.
All right, thank you. Our next question is asking regarding high blood pressure, what constitutes readings for concern?
Yeah, so I think so in general, if your blood pressure is running over 140 over 90 consistently, like if it's over that every day, that's a cause for concern. And I would bring that to the attention of your primary care doctor or the doctor who's treating your blood pressure. If you are having very elevated blood pressure readings, like we're talking over 170 or 180, that's a cause for concern as well that I would bring to the attention of your doctor. If it's just once in a while, your blood pressure is a little bit elevated, I think it's okay. Like if it's like this person was saying 140 over 95, I think that's fine. But where you want it to get something adjusted or looked at is if you're consistently, every day, 4 or 5 days in a row, your blood pressure is running high consistently, then you may need to make a change. Our bodies change with time, and blood pressure is one of those weird things that for some reason our bodies regulate differently. And we may be on the same medications for years, but for some reason something changes in our body and our blood pressure starts running high. So if it's consistently running high, I would bring that to the attention of a doctor.
All right, thank you. I apologize if I mispronounced this word, but what is the risk of getting TPA with a hemorrhagic stroke?
Yeah, so I think the question may be worded backwards there. Um so like I was saying before, there's two types of strokes. There's the bleeding stroke, and then there's a stroke where we lose blood flow to the brain. Okay. And like I was saying before, we want patients in the emergency room right away, and we want to get a scan of their head to make sure they're not bleeding. And the reason we want to make sure they're not bleeding is because if they're having a significant stroke, we have this powerful medication called TPA, which goes in and dissolves blood clots throughout the entire body and tries to restore blood flow to the brain. Okay. Since it's a powerful medication that goes in and dissolves blood clots and restores blood flow, we cannot use it in somebody who's having a bleeding stroke or a hemorrhagic stroke. So people who have a hemorrhagic stroke cannot get TPA. If somebody's having the other type of stroke, the ischemic stroke, where the blood flow is cut off, they can get the TPA. We reserve using TPA for people who are having significant strokes that would leave them disabled. And the reason we reserve it for those cases is because it can cause bleeding. It's one of the serious side effects of it. It can cause bleeding in the brain as a side effect of the medication. When the medication was originally approved back in the 1990s, the original studies showed that it had about a 6% chance of causing bleeding in the brain. Over time, that number has come down a lot. It's about 3% now. So about 3% is what the risk is of bleeding in the brain if you get TPA.
All right, thank you. Does AFib contribute or cause stroke?
AFib is one of the number one causes of stroke in this country, especially in elderly people. It absolutely causes stroke. If you have AFib and you're not on a blood thinner, there should hopefully be a good reason for you not being on one. Um, Absolutely, AFib causes strokes. We see probably every day in the hospital here.
All right, thank you. Can you speak about TIAs?
Yes, I can speak about TAs, but I think there was one other question in there. I'm looking at the questions here too. So somebody had a question about a CPAP machine. Will using a CPAP machine minimize, reduce, or eliminate the risk of a stroke? Uh, Frank, this is a very insightful question, and the answer is that we actually don't know. And here's why. Like I mentioned before, sleep apnea, for which is treated with a CPAP machine, we know is associated with stroke. We know it increases the risk of stroke. We know it increases the risk of heart disease. We know it increases the risk of high blood pressure. What we don't know for sure is does putting a patient with sleep apnea and a stroke on CPAP reduce the risk of a future stroke? And the reason why we don't know that answer for sure is because we don't have enough studies that have addressed that question specifically. So we know that it's associated with it. That's why we recommend patients get treated with a CPAP. But to be 100% honest with you, the research evidence out there is not yet conclusive on whether does CPAP actually reduce that risk of stroke. There are some studies ongoing right now that are addressing this specific question, so we should have more information in a few years. And then the next question was about TIAs. So TIAs are a TIA stands for a transient ischemic attack. Okay. And like I mentioned before, we have the two types of strokes. And the one type of stroke is the ischemic stroke. The blood flow gets cut off. That part of the brain that needs blood starts dying out. That's an ischemic stroke. A transient ischemic attack is when part of the brain temporarily loses blood flow. Okay, a blood vessel gets blocked off, that part of the brain stops getting blood flow. If it's the part of your brain that controls your speech, it produces a speech difficulty. If it's part of your brain that controls your arm will go weak, but it's transient. So transient ischemic attack. So for whatever reason, that blood flow gets restored to the brain and your symptoms go away. So you have temporary stroke symptoms. And when we get an MRI of the brain, we don't see any permanent damage because that blood flow was restored for whatever reason. We treat TIAs the same as we treat strokes. Many times when we have our patients with stroke, we hear or we find after talking to them that they were having TIAs beforehand. So it's a warning sign of a stroke. You're at high risk of having a stroke after a TIA. So usually when you come into the hospital, usually when somebody comes into the hospital emergency room with a TIA, they'll end up getting a full stroke workup. They'll get an MRI of their brain, an ultrasound of their heart, all the typical things that they would get if they were having a full-blown stroke. Because it's basically the same process as a stroke, but it didn't quite get to the point where it caused permanent damage in the brain.
All right, thank you. Is an aneurysm a stroke?
This is a good question because we get this question a lot. An aneurysm itself is not a stroke. An aneurysm, I want you to picture like a blood vessel going like this, okay? It's like a pipe. There's blood flowing through it. An aneurysm is when part of that blood vessel wall gets weak and it pouches out like this. So there's a little pouch on that blood vessel wall instead of it being smooth like this, okay? That's what an aneurysm is. It's like a little bubble or a blister on the wall of that blood vessel because that part of the blood vessel got weakened. Aneurysms can cause bleeding strokes because they can burst. And if you imagine an artery bursting in your brain, it can be pretty devastating. So aneurysms in and of themselves are not a stroke, but they can cause a type of bleeding stroke when they burst. So that's why when we discover patients who have aneurysms, many times by chance, we keep an eye on them. And if they're big or showing dangerous features, we generally recommend they get treated so they don't cause bleeding in the brain or a bleeding stroke.
Okay, thank you. Our next question is a little bit more of a personal experience. It reads, I experienced 2 episodes of retina arterial occlusion 13 months apart, same eye, diagnosed as having a stroke. Is this something you've seen before?
Yes, it sounds like this is probably what's referred to as a central retinal artery occlusion or branch retinal artery occlusion. And so, I mean, that's my guess based off just the limited information from your question. Obviously, I don't have your medical records, but that's what I would assume you're referring to and what happened. And so, basically, that is as we talked about an ischemic stroke, blood supply cut off to a part of the brain. If for some reason a clot goes up to your eye, uh, that then it basically is a stroke of the eye, is a retinal artery occlusion. So again, we treat it similarly to how we would treat a stroke. We do the same type of testing and workup for it. So it's definitely something we encounter quite frequently.
Okay, thank you. This next question is again a little bit more of a personal family experience. Someone is asking on behalf of their family member who's had a stroke in their 70s, actually two strokes within a week, and they would like to know what future risks are. AFib was discovered after the first stroke, and the second stroke was worse, but occupational and physical therapy had helped. They are mobile and able to get around and live alone, but overall just curious about future risks. It's been 6 months since the two strokes.
Yeah, so if we mentioned AFib a little bit earlier, so AFib increases your risk of stroke a lot. It's associated with, it's one of the most common causes of stroke. So if patients are on the appropriate treatment for AFib, which is typically in most cases a blood thinner, then that reduces your stroke risk down to about 1 to 3% per year. So it's not perfect. Your stroke risk does not get down to zero, but you're still at about a 1 to 3% risk of stroke. Certain things can increase that risk of stroke. For example, if you have other medical conditions that are, the high blood pressure, diabetes, cholesterol that are uncontrolled, that can increase the risk of stroke. If you have blockages in some of the arteries, that can increase your risk of stroke. But in general, if we're just talking about somebody who has atrial fibrillation and their strokes are from it and they're on a blood thinner, it brings down that risk to about 1 to 3%. So in general, the recommendations that I would have for somebody in that situation or anybody who's had a stroke are making sure those underlying medical conditions are also addressed. The blood pressure is controlled. If they're diabetic, their A1C is in a good level, their sugars are controlled, their high cholesterol, if they have high cholesterol, is controlled. They're taking their medications and making some of the lifestyle changes we talked about today.
Okay, thank you. Can you clarify ways to differentiate between stroke symptom and Bell's palsy, since they both involve a type of facial muscle weakness?
Absolutely. This is another great question. And as neurologists, we're actually frequently called for this exact same question in the emergency room. So there's one crucial difference between a Bell's palsy and a stroke causing facial weakness. A stroke will almost, for the vast majority of time, will cause weakness in the lower part of the face only. Okay, so it will cause drooping of the face. You may there's something called a nasolabial fold here, which is this crease in our face right here. This will go flat compared to the other side. People are not be able to smile straight. So a stroke generally affects the bottom part of the face here. Okay. A Bell's palsy will affect the entire face. Okay, so the top part of the face will be affected too. And so you will see that someone cannot lift up their eyebrows on that side. When the top part of the face is paralyzed, you actually cannot close your eye. So the eye will be stuck open and it'll be hard to close it. You'll notice the wrinkles smooth out in this part of the forehead as well. So Bell's palsy affects the whole side of the face, the top and the bottom, whereas a stroke generally, except for very rare circumstances, affects only the bottom part of the face.
Okay, thank you. That was our last question. So I just wanted to say thank you again to Dr. Qureshi for your presentation and insightful Q&A. To all our participants, thank you for joining us, and we hope you have an excellent rest of your day.
Thank you very much.